Kia ora, welcome to this Goodfellow Unit Webinar on talking about alcohol and the conversations we can initiate with our patients around alcohol issues. So now I'd like to introduce our expert speaker tonight. It's Dr. John McMenamin, who's a GP in Whanganui. He is an expert and has spent a lot of time developing research and tools around talking about alcohol issues and brief intervention. So welcome, John.
Thank you, Helen, and kia ora, everyone, and thank you for checking in for this interesting subject tonight as we talking about alcohol. And the first slide is opening the can of worms, which is a way a lot of us sometimes feel about when we're talking about alcohol. What is it that we're going to be getting into? So talking about alcohol in general practice, and you might just like to think about jotting down some of the questions that are coming up tonight with respect to being able to use them in the consulting room. And something I find quite helpful is to, when I'm learning new questions, is to jot them on a post-it note and then stick them on the edge of the computer, and you have a chance to practice them during the following week or two. So you might like to try that, maybe jot the questions down and transfer them onto a post-it note to test them out. We have lots of opportunities for talking about alcohol in general practice, of course, both in our GP consulting rooms and our practice nurse consulting rooms, and of course with our community pharmacy colleagues, during consultations, during treatments when we're providing wound care and so forth, during planned opportunities, and in our pharmacies on medication labels, injuries, and I'm told that even some people come in for hangover cures, which may be an example of an opportunity to talk. So straight into talking about alcohol, how do we do it? And the first thing I like to recommend is that we ask permission. Asking permission is a good way to just ease into a subject. Is it okay if I ask you some questions? Most people say yes, and if you feel you need to, you can just affirm that confidentiality is an important part of it. So can I ask you some health questions? Sometimes if you don't want to go straight into talking about alcohol, you can lead in with diet, exercise, smoking. Can I ask you some questions about your diet? Can I ask you some questions about exercise? And then just in the natural sequence that follows, can you tell me about your use of alcohol? So that's just kind of a good way to get into the questions and open up the subject. Really, my recommendation for the next series of questions is that you actually find out how much someone is drinking. And so the best way to do that is just to ask what are called the audits or consumption questions. That's frequency, quantity, and then a question about binging. So how many days in a week would you have a drink? When you are drinking, how many drinks would you have? And how often would you drink more than 4 or 5, depending on gender? And these questions just give an opportunity to get a sense of where somebody might be at in terms of their total consumption. And all we're really trying to do here is find out, is this person likely to be drinking under low-risk guidelines, or are they likely to be drinking above low-risk guidelines? And the reason that we're asking these questions, of course, is because we know that when we are looking at alcohol, the amount that a person drinks is going to contribute to health risks. For some people, it's going to cause problems, and for some people, it's going to be associated with dependency. We know from the New Zealand Health Survey, that's a year old now, that 20% of us drink in ways that could harm ourselves, higher in men than women, as we know, much higher in young people, as we would know from our everyday experience. Mm-hmm. And we also know that there's lots of long-term health effects from drinking alcohol. There's a little chart here, which is from the Health Promotion Agency. You can find this very easily on the HPA website. And it shows all the different places in the body where alcohol may impact negatively on a person's health. Quite a good way of upskilling yourself around this is to bring up this picture sometimes when it's appropriate to do so, and just go through it with the patient. So that might be, and as we'll talk a bit later, can I share some information with you about how alcohol might impact on your health? And bring up a picture like this, and then as you go through it, not only does the patient learn, but you kind of reinforce your knowledge yourself, and enables you to talk about it more easily. So I think it's helpful to think about alcohol in terms of risks, problems, and dependency. And in our first series of questions, really what we're doing is assessing risk to see if somebody is drinking above low risk guidelines. So right at the start, good question, how good are we at talking about alcohol? And this has been researched recently in 2011 in a paper in New Zealand where the analysis of consultations that used audio taping showed what was described as interactional delicacy on the part of both the doctor and the patient, manifested by verbal and non-verbal discomfort. So that little mouthful phrase basically says we feel a bit uncomfortable sometimes talking about alcohol, and we're a bit cautious about opening the can of worms. And what those audio tapes showed was that our discussions around alcohol tend to use a lot of closed statements, a lot of understatement, wry humour, we're very good at that, and sudden topic change as we veer off and move away. And yet it doesn't need to be like that. Talking about alcohol is not a difficult thing to do, and I'm going to share with you some questions that would be very useful for us to do that. Another study which used video recorded primary care consultations identified that some of the reasons that we don't want to talk about alcohol are because it takes time, or we perceive it takes time. Because of embarrassment, it can be a difficult subject to enter, or at least we perceive it as being difficult. Sometimes because there's other people in the room and we don't think it's appropriate. Sometimes because of the way in which our practice systems are set up, so that we feel under pressure, we don't have an opportunity set up to be able to have the discussions. And sometimes just because we simply don't know what to do. If somebody says, yes, I am drinking above low risk guidelines, yes, I might have a problem, yes, I might be dependent, what are we going to do with that? And we might not feel comfortable. And yet, really, we have all these skills because we use these skills in so many other areas of practice. They're the same generic skills that we use when we talk about smoking, the same generic skills when we talk about taking medication, changing people's lifestyle around diabetes and so forth. So there's nothing particular, it's just the particular content of it that might be a little bit different. So here's a good question. If you're really busy and you've only got time for one question, this is a good question to ask. How many times in the past year have you had 5 or more drinks in a day? So you can always toss in at least one question, and that question has got a fairly reasonable sensitivity. It's not going to pick up everybody, but as you can tell from the basic question, it's one of the audit C questions. It's going to let you know, is it likely that this person is drinking at risk? It's not the full audit, so you're not going to get all the questions that you would get when you do a comprehensive screen, but it's going to be one that you can just put in there if you are very busy and only have an opportunity for one question. And what it's going to lead you to doing is assessing that person's drinking against low risk guide. And this is the low risk table from the Health Promotion Agency. You can find this on alcohol.org.nz. Very easy to find. If you have the Alcohol ABC program on your computer, then this is one of the pictures that's in that. And it's a very useful picture to bring up with people, because you can simply ask the question, here are the low risk drinking guides, how does your drinking compare? And so you can say 2 standard drinks a day or 3 standard drinks a day, no more than, for reducing your long-term health risks, 2 alcohol-free days, or on any one single occasion, no more than 4 or no more than 5. Reducing your risk of injury is a good way of introducing that. And if you're pregnant, no standard drinks, and I'll come back to that one in a minute. And a good way of just opening up the subject and putting the issue really where it belongs, that is with the patient to describe for themselves what's happening with their drinking, is to take the information they've just shared with you about either their quantity, frequency, or whether they may on occasion be drinking above 5 drinks, and how does it compare against this. And then that does lead into a discussion about what low risk drinking is about. And the advantage of the language that's being used here, low risk drinking, is first of all it does identify that any drinking has some risk depending on the circumstances, machinery, other medications and so forth. So there's no such thing as no risk drinking. But also it's not in any way blaming anybody. It's just saying here is a way of assessing somebody's risk. It also leads on to a discussion about actually what is a standard drink. Many people will be familiar with that because all our alcohol bottles are labelled with standard drinks, but quite a good practice is to ask somebody to take a cup and just fill it with so much water and indicate to you what a standard drink would be if it was a wine or a beer. And generally, most people would overpour in that situation. Perhaps we might even do the same. And so it is quite useful to know what a standard drink is. It's 10 grams of alcohol. So that's on average around about 100 mils of standard wine, just under a can of beer and so forth. And I think it's just very useful to share this information with patients. Again, what's in a standard drink is available from alcohol.org.nz, very quick to find, and very useful to share that back with patients so that they can then reflect on their drinking and get some sense of actually how many standard drinks it is that they are using themselves. A good thing about alcohol questions is that it does allow patients to talk about their concerns. So we sometimes think that people don't want us to talk about alcohol, but the work that was done here in Auckland on the chat tool, so that's the case finding lifestyle and mental health disorders and primary care tool, that tool, which is available as electronic or as a paper tool, given to general practice patients in that setting, it also asked, would you like help with whatever the problem was? And nearly 11% agree that they would need to cut down on their drinking. So that's a lot of people to talk with who actually will respond, yes, I am interested in having a discussion. Perhaps I need to talk down, perhaps I need to cut down, perhaps I do need to have a discussion around alcohol. So we do know, and certainly if you ask patients, you will get this back, that it is an appropriate thing to talk about. The more we talk about alcohol and other similar issues in our everyday practice, the more our patients get to experience that is what general practice, what the agenda in general practice is, and will have an expectation that it's appropriate for you to do so. So I've been talking about alcohol with my patients for over 30 years, and there's an expectation amongst my patients that I'm going to enter into this area and have a discussion with them. And so very seldom will I find any resistance to that. So again, some Australian work has identified that there are barriers to us asking the same sorts of things: lack of time, competing issues in patients. They've got their own agenda, of course, and we've got lots of other items on our dashboards and patient prompts that are encouraging us to look at other things. Fear of eliciting negative responses. So that is a fear, and I think that is often resolved by the way in which we ask the questions and by an expectation that it's appropriate, and then low confidence in our ability to manage alcohol-related issues, which once again I really want to reiterate that the problem solving that goes with alcohol is no different from the problem solving that goes with any other subject that we manage as well, and we don't lack confidence around those, and we don't need to lack confidence around alcohol as well. It is a busy space, a very busy space. Patients come with their list, with their problems. Somebody else often comes, or else you see somebody else in the room, you think, I must deal with that while the person's here. And then also we have a number of items of things that we think are appropriate to talk with patients about as well. So it is a busy space. So how do we find time for that? So one of the options is to use a reminder process and a recording process. Some of you will be familiar with Alcohol ABC. So the ABC is matched on the tobacco ABC and asking about alcohol, offering brief advice or brief interventions, which I'll talk about in a minute. And then the C is offering counselling, either yourself or with somebody else if it's required, which in fact, referral is not required for most people. And there is a tool, it's available through the college website to understand what the tool is about. And that tool offers quick recording tool. So there's first of all a reminder. In this case, it's a dashboard reminder. Some other people will have patient prompts as reminders. There are lots of different kinds of reminders that's useful to us to have. Have I talked with this person about alcohol before? It's good to know, yes or no, if you have. The recording tool with a quick prompt just allows you to quickly record, especially for people who are not drinking or who are drinking below low risk guidelines, because that in fact is the majority of people. We can tell from the health survey that 3/4 or more of people are going to be drinking in a way that is not likely to be impacting on their health. So we can then quickly, in a sense, dismiss any need for further intervention with those people. So it's really only a proportion of our patients, maybe 1 or 2 out of 10, that are going to need any further follow-up. The advantage of having a tool like Alcohol ABC is that it contains some resources. These resources are also available on the Health Promotion Agency's website, and you can access them through alcohol.org.nz as well. One of the ones I like is a tool which allows you to record how much a standard drink is, and therefore how many standard drinks a person is drinking. So there's a series of pictures of drinks, and people can click on them, and it will automatically summarize how many standard drinks that the person is having. There's quite a good tool on the alcohol.org website, which allows you to, in fact, pour out how much you're drinking, and it will tell you how many standard drinks that is, so that's useful too. And then for those people who are drinking above low-risk guidelines, the option with this tool, and the option, in fact, for all of us, is to move on and complete the full audit. So the term audit stands for Alcohol Use Disorders Identification Tool. It's been around for a long time. It was being well validated in New Zealand. New Zealand was one of the countries that took part in the World Health Organization development of this tool, or back in the last century actually. And so it's a well validated tool, and it works well. It's got 3 sections. The first is the consumption questions, which you have already asked, so will just be auto-completed. And then the next section's got some questions on dependency, and the next one some questions on whether a person has problems. So again, it's like thinking about risk, problem drinking, and dependency. And it gives feedback to the patient. It's a great tool to be able to shift your screen in front of the patient and do with them, and allows you to decide with the patient what the answers are, and then actually read the feedback together, which can be quite a neutral way of giving information back to a person without you necessarily having to actually tell them what that is. So if you've got this in your system, that's great. You can use it through the ABC tool. If you haven't got access to this there, the same tool is available on alcohol.org.nz, and it's very easy to access and very easy to use as well. These tools are supported, as I mentioned, by the College of General Practice. There's a write-up on the website of the college about supporting this in your practice and how you might go about it. And then it's also supported in the NZMA's policy statement on reducing alcohol harm. So well worthwhile reading the NZMA statement, because it not only supports our work with screening and brief intervention, but also it stresses the importance of a public health approach, particularly looking at public health approaches that will reduce access to alcohol and will reduce access in the sense of cost, because there are some public health interventions that are very necessary for population health approaches to alcohol. And to a certain extent, unlike tobacco, where we are very supported by a public health policy, in alcohol, we're kind of on our own really much more when it comes to dealing with alcohol, because we don't have that backup, and alcohol is so cheap and so easily available. If you've got a little bit of extra time, 2-question screening is a good way to screen. Have you ever been hurt as a result of your drinking? Combined with, do you sometimes drink larger amounts or over a longer period than intended? These have a higher sensitivity and a better specificity, so they're good questions combining the two. You'll see that the one about being hurt is a problem-based question, and the one about drinking larger amounts or a longer period is a dependency-based question. And again, they're just useful questions to introduce into a discussion around alcohol, particularly if you're just in the process of gathering some information without doing a comprehensive audit or a full alcohol assessment. So useful questions. You might like to jot those down. Have you ever been hurt as a result of your drinking? Do you sometimes drink larger amounts or over a longer period than you intended? Very useful. However, here's my personal favourite, so you might like to jot these ones down as well. This is the 3-question option, the you, them, me approach. I find this an extremely great go-to place if I get caught out in a discussion around any health issue, but especially it's useful around alcohol use, because it focuses on a motivational approach. So do you have any concerns about your drinking? Does anyone else have any concerns about your drinking? Or can I share with you my concerns about your drinking? So first of all, do you have any concerns about your drinking? And if a person says yes to that, then clearly they're quite motivated to do something about it. If they say no to that, a very good entry point then is, does anyone else have concerns? Because a lot of people will own up to having somebody else concerned about their drinking, their spouse, their parent, somebody, a friend, somebody in their life. If they say no to that, then you've got somebody who basically is not really that interested in addressing alcohol. And so you can, if you think it's important, say to them, can I share with you my concerns? And then you can address your concerns in a variety of ways, and I'm going to touch on what those might be. So that's just quite a useful one. And if there's any one approach I'd recommend, just write down you, them, me, and test out those questions over the next week or so. Sometimes screening and brief intervention, that is using the ABC approach, asking, we just simply can't fit it in. And if that's the case, and if it's a case in the short term, that's fine. If it's the case in the long term, I think we need to think about how we're structuring our workload, because we do want to address this issue and we don't want our workload to totally get in the way. But an alternative approach is being recommended, and extra points for anybody who spots the spelling mistake on this page. But the alternative, or actually complementary approach, is called pragmatic case finding. And this is when you look at situations in which alcohol is an item as part of the situation that you're managing, and bring it into the discussion. There's a really good BPAC journal article. So as ever, you just need to Google BPAC and put alcohol next to it. You bring this article up. When to suspect alcohol misuse, and it talks about situations where alcohol may be relevant. So that's unintentional injuries, abnormal liver function tests, and also elevated mean cell volume, dyspepsia, depression, relationship problems, and hypertension is a really good one to think about. Alcohol is a very significant contributor to hypertension, and is easy to overlook and may have quite a significant impact on reducing blood pressure if it's addressed. So those are clinical scenarios where alcohol can easily be brought in, but then there's lots of situational scenarios as well. And I think about new patient assessments, contraceptive prescribing, pregnancy assessments, medication reviews, falls assessments, and you probably think of others where it's easy to bring alcohol in, so that you're not just screening asymptomatic patients here so much as bringing alcohol into a clinical scenario where it may be more easily discussed. And if you are doing pragmatic case finding, these are really good questions. So whether it's somebody presenting with dyspepsia, or somebody with abnormal liver function tests, somebody with hypertension, good questions would be, what do you understand about how alcohol affects your health? What is the effect of alcohol on this problem that we're discussing? What's the effect of alcohol on your blood pressure, do you think? Could alcohol have been involved in this injury? Just general questions like that allow a person an opportunity to respond. Alcohol can affect this problem. They may not be aware for blood pressure. Alcohol can affect blood pressure. You may not have been aware of that. It can increase blood pressure over time. What are your thoughts about this? So just general opening questions that tease out for us our opportunity to use clinical scenes in which we can discuss alcohol. I want to just mention a tool that's going to be available soon, that will be available to all of us in practice, and that I think will be very useful. A tool being developed here at the University of Auckland, which is going to be an alcohol risk assessment tool. So we're very used to risk assessments in practice. We do our cardiovascular risk assessments all the time, and this is going to be a very useful tool. One of the benefits of a tool like this is that we're going to be able to change a person's risk status by looking at different factors that would adjust where their risk status lies, much as we can do with the cardiovascular risk tool. So I just mentioned that that's coming because that is an opportunity that we will have in these situations where we're talking about alcohol, to look at discussing, here are some options for you that you may want to consider that could reduce this risk. And as ever, when we have a kind of external information on a screen, it can sometimes be a very helpful way of doing that. I also want to just touch on alcohol and pregnancy. We know there's no known safe level of alcohol consumption during pregnancy, and there's a very good drinking in your baby pamphlet from the Health Promotion Agency that you can access and share. We know that we as GPs are likely to be the first point of call for many women when they become pregnant. We know that over 70% of pregnancies attend general practice within the first trimester, and so we have lots of opportunities, and we know that the alcohol harms very often may occur in the first trimester, and so our opportunity for early intervention here is really quite critical. This is some information from the Health Promotion Agency about what we need to know about alcohol in pregnancy. First of all, that there's a number of myths in the population about alcohol and pregnancy, and we have a very specific job as kind of respected educators, really, to help dispel those widely held myths. It's important that we talk that alcohol can harm a baby at any stage of pregnancy, and that includes very early on in the pregnancy, that there's no known safe amount of alcohol, and that all types of alcohol can harm a baby. And also, just to be very straight about the message that if you are pregnant, stop drinking. In fact, the message really goes beyond that. It's if you are pregnant, or you might be pregnant, or you are thinking about becoming pregnant, you should stop drinking alcohol. We know also from research in Australia, and it's very relevant here in New Zealand, women want to be asked about alcohol use during pregnancy. It's not that we should be shying away. Women who are pregnant want information, and it's very appropriate for us to be sharing that information. So talking about alcohol is important, and it's important really through the childbearing age, and particularly not just in early pregnancy, but in those situations that might arise in practice where we might want to consider pregnancy as an option. So that would include lots of well-person checks in younger women, contraceptive checks, STI checks, and so forth. So there are lots of opportunities there that we might need to think about it, but really just reinforcing our role as health professionals here to be very clear about that message, and the message basically being there is no known safe drinking in pregnancy. So we're talking about brief intervention. How effective is it? So here's a very easily findable World Health Organization reference book, which, if you'd like to know more about it, is well worth reading. These are from the world leaders in brief intervention, and it's called Brief Intervention for Hazardous and Harmful Drinking from the World Health Organization. Very easy to find. Again, it's just a Google of brief intervention World Health Organization will find that. But the bottom line is multiple studies, including multiple randomized controlled trials and multiple reviews of randomized controlled trials, have verified that brief interventions can be delivered within a primary care setting, that they are an effective way of motivating patients to reduce risky or harmful drinking. So we know that the questions that we're opening up and that are leading into a discussion are very appropriate questions, because the outcomes of those questions can be an impact on our patients' drinking behaviour. It's not, we don't have to be nihilistic about talking about alcohol. What we say does make a difference. In fact, a recent Cochrane report identified that brief interventions are as good as longer interventions. Now, these people are talking about brief interventions from an alcohol background, so a brief intervention for alcohol specialists is probably a little bit longer than what we would consider a brief intervention in general practice. And I'd probably differentiate here between brief advice and brief interventions. So we do give a lot of brief advice, and that is still an effective thing to do. A brief intervention is a little bit longer. It typically would include giving some feedback about alcohol use and harms. It might include looking at high-risk situations, in other words, going through with a person about what the situations in which they might be at risk. It might include advice about cutting down. It would probably look at some motivational enhancement, and it might even include a personal plan. So you can see that's not something that you're going to be doing while the subject's raised in another consultation. But there's nothing in providing a brief intervention that cannot be done by any general practitioner or practice nurse or nurse practitioner within a primary care environment. Many people will come back after you have raised these initial questions and be willing to talk through some of these issues. Lots of ways of getting people back, sometimes simply asking them. Sometimes, of course, you do a blood test to check out their liver function or their immune cell volume, and you can say, look, there are some blood tests that will be helpful here for us to identify what might be happening around your alcohol. I'd like to see you for a follow-up, and as part of talking about that, we can talk more generally about your alcohol, and then set up an opportunity to do that. If you haven't set up an opportunity just to talk to someone about alcohol, I'd certainly encourage you to do so. It's an interesting area to work in. People are grateful for you to be involved in their life, and you can make life-changing events for people, and so very much worthwhile. Interesting thing that this kind of intervention, 1 session, 2 sessions perhaps, with a general practitioner, practice nurse or nurse practitioner, may be as effective as many of the longer term interventions, and that's because you're reaching people at their point of need. You're coming from a very powerful situation as a respected health professional, and you're doing it in an appropriate way within a setting that they're willing to receive help. So let's not underestimate our capacity to make changes for our patients here. So we talked about some of the initial questions, just getting into it questions, but where do you go from there? And I'd like to talk about sort of bridging then into kind of getting some motivational assessment about what's happening. So that's when I like the questions that would indicate where somebody is at around a motivational stage. Here's another example of that with the, have you ever felt a need to cut down on your drinking? I think that is a question, as we mentioned before, that gives some sense of where a person's at, and the other one about anyone express concerns about your drinking. So these are good questions, because if a person answers, how a person answers, that will give you some sense of where they're at. Now, commonly, and probably more commonly than not, you will get "I'm not interested" sort of response. My drinking's okay, Doc, don't you worry about that. So these are the people who are not interested, and they're in the pre-contemplative stage perhaps. And so what's a brief intervention for these people that might be helpful? Again, I think you go back to permission. Can I check out a few areas where drinking may affect you? We know that there are some areas where drinking may affect a person. Can I ask you about those? And then I like to go through the 4 L's. That's liver, lover, livelihood, and law. So that's just thinking about some domains of a person's life where alcohol might have an issue. Now, this is particularly if you have somebody coming in where it's quite clear that alcohol impacted on the reason for them being there, but they won't go there in terms of a discussion. I do ask permission. I'm usually very gentle about it, but I say, can we have a look at the relationship between alcohol and either what's happened here today that we're dealing with or some other physical health issues? Is alcohol impacting in your life in any way in terms of your relationships? And that can be teased out a little bit. Any issues at work, particularly thinking about Monday issues, but also have you ever had any issues arise at work around alcohol impacting on your employment? Legal consequences, so it's amazing how often somebody will just at this point come and say, oh, I've had a couple of drink driving offences, or yes, I have been picked up regarding being drunk. So thinking about legal consequences, and because sometimes people just don't actually think about that as a consequence of their drinking. You'll see this is very similar to a kind of 360 or a heads type assessment. It's really just about looking at the different domains in a person's life and teasing out, might there be something, and you might specifically focus that according to whatever is appropriate for that person. Another way in is to ask the question, can I share some information with you about alcohol? So if somebody's come in with health issue, this is one opportunity where you could bring up that diagram and say, look, alcohol has quite a lot of impacts on the body. Can I just go through this with you so at least you understand about that? Another one is to think about whether anybody else might trigger an interest. Would it be helpful if others shared this conversation? Is there anybody else important to you that if we were talking about alcohol, it would be good if they were here? It's kind of just a little bit of a nudge to say, there may be somebody in your life who thinks a little bit differently from you. Perhaps they would like to come. If you're seeing somebody for a problem like an injury follow-up, might be an ACC follow-up, you may be doing paperwork and so forth. Look, at your next visit, why don't you bring so-and-so with you? We could just have a little discussion, see if they have any concerns. It's all permission-based, it's all voluntary, but it may well just tease out a little bit of that sort of cognitive dissonance that people might need to just move them a little bit towards being keen to have a discussion. I'd also recommend the Alcohol and You book. This is from the Health Promotion Agency. Again, it's available through the alcohol.org website. You can just Google Alcohol and You pamphlet HPA and that will bring it up as well. And the great thing about these booklets is that it's just a way of sharing information that you don't have to give everything yourself. First of all, you don't have time to give everything yourself. Secondly, sometimes it's difficult to remember everything you might want to say. And thirdly, it does mean the person goes away with some information. What I like to do is to take that website at the bottom, and you can just copy that URL off your computer and put it into a text-to-patient messenger. So I'm very familiar with the text to remind process. I would just open an outbox, pop that web address into that and say, look, I'll just share this with you. And then the person carries it away on their phone and then they can open it at their leisure or open it on a larger device subsequently if they want to and go through it. I find that a really useful way of leaving that with a person.
John, just so everyone knows, we'll put the links to all those booklets and the web addresses on the website with the webinar resource after this is finished.
Great, thanks for that, Ellen. That's good. Now, if you get somebody whose brief intervention indicates that they might be ambivalent, so I've thought a little bit about cutting down. Maybe once or twice I have attempted, it hasn't worked very well. Whatever, some indication that there's a little chink there that says, yes, I'm interested to talk. Then I again say, can I check out a little bit more about your drinking? And these are really useful questions in this situation. How does it compare with a year ago or 2 years ago or 5 years ago? You choose the time you think is appropriate. Those are good because if you find that somebody says, oh, I'm drinking way more than I was a year ago or 5 years ago, you can then tease out, well, what's been going on that's created that situation. And then if somebody says, oh, no, I don't really drink as much as I did then, oh no, I've definitely cut back. Oh, well, what was it that caused you to cut back? What was going on? What are your concerns? And so forth, so you can also then tease that into the future. Where do you see it going in the future then? Where do you see your drinking in the future? A lot of people don't think about it like that, but looking into the future is a good way of encouraging thinking about change, because what we're trying to do here is to shift that ambivalence towards actually some action, and any of the questions that will tease out ambivalence will be useful. Any book on motivational interviewing, and there's loads of information on the internet about motivational interviewing, will give you questions that you can ask around the ambivalent stage, and any of the questions you can just relate to alcohol will enable us to tease out. And so again, I would say, look, can I give you some information to read? And the information I would use is your drinking okay? So it's another one of these booklets. Again, I would text out this booklet and share it with the person, and it's going to reinforce all the things that you've said and just increase that cognitive dissonance around the drinking and maybe shift somebody into an action stage. Then you do get some people that are interested, and you do get people, you say these questions, say, okay, I would like to know more about this. I am interested in stopping. I am interested in cutting down. I am interested in knowing more about alcohol. So then obviously we want to put this back onto the person to own this and look at what it is that they are going to do to own the problem and make the changes. It's not about them giving the problem to you to solve their problem. It's about them owning the problem and coming up with solutions that are going to be successful for them. If you wanted to cut down on your drinking, then how would you do that? And people will come up with suggestions that you can then explore. What changes would be needed for that to happen? So those are questions, those are really good questions for teasing that out, because it makes people think. And as they think and answer you, they're owning the problem, but more importantly, they're owning the solutions. And then what might make it difficult for you? And that's them looking at the barriers and thinking about the barriers. So those kinds of questions, there's lots more that you'll find in motivation interviewing websites, but those kinds of questions will shift the issue back to the person, help them to own the problem, help them to look at how they might address that themselves. And then again, how can I provide some information? And the information is cutting down. There's a great pamphlet, again, can text it out, and in that will be some very specific problem solving stuff. So there's lots of information in here. It's not just practical ideas, but it is good to discuss practical ideas, and you might do that at that appointment. You might do that at a follow-up appointment. I've just highlighted a couple of ones there. Keeping a drinking diary is a really useful thing to do. It helps people to get a better idea of how much they're drinking, and particularly if they convert it to standard drinks, it continually then reinforces what that means. A recommendation to keep under a daily cutoff so they can give themselves a tick in their drinking diary when they do that. Asking someone close to be a partner in reward, so that's about sharing this, because it can be a very lonely journey trying to change your drinking. Defining something like having at least 3 alcohol-free days a week and putting big ticks on the page there. It's not for us to suggest the changes, but sometimes having a menu of options is a really useful way of saying, well, look, here are some ideas. You may have some other ideas. Which of these might work? What might we talk about? And this is one of the reasons why brief interventions in the sense of a 10, 15 minute, 20 minute, maybe half-hour discussion as appropriate can be really useful, because what we're really doing is giving ownership to the person to come up with their own ideas. And we know from our own behaviour, when we own it ourselves, we'll do what we want to do. And our patients are, of course, just the same as that. So at the end of these sessions, then, whatever it is, whether a person's thinking about it, deciding what to do, or actually having some actions, it's good to have some way of finishing off. Otherwise, it just gets left hanging, and that's a bit awkward. So we're not in favour of awkward. Who can support you with your thinking, deciding, actions? And this is a really good one, because sometimes a person can feel very alone around alcohol. They may have some shame about what's happening. They may be hiding what's happening. Being willing to share this with other people. It might be somebody very close to them. It might be somebody that can act as a mentor. It might be somebody else at work. It's very helpful if they bring somebody else into the process, or even just sort of saying, we've talked about a lot of things about alcohol. Does this make sense to you? I mean, that's a very good question generally in our work, of course, and asking people to repeat back what it is, that sense of ownership that comes with that. Would you like me to arrange a follow-up chat, or could we follow up at your next visit? Getting permission, even for somebody who's pre-contemplative, to say, look, this is, I want this on the agenda for our next visit. Is that okay with you? And being explicit about that is fine. So you say to somebody, well, we haven't really had much of a discussion, but next time you're in, is it okay if I just check in with you about how your drinking's concerned? Sometimes we're just amazed. You check in next time and that person has completely changed their drinking simply because we raised the issue, and the rest of that motivational wheel happened without us. Would it be helpful to talk with an alcohol specialist? It's a good question to discuss. You may have somebody in the practice that specialises around alcohol, and that's a great thing to do if you can have that, some clinical person in the practice that will provide that time and that opportunity. Or obviously we have referral options as well. And then just a general, is there anything else that you would like to know? Obviously, I'm not going to ask all these questions, so hence my suggestion, sometimes just jotting down and practicing with the different questions, see what fits, and choose what seems to be the most appropriate one. So that's probably a good place to take a break.
Well, there are a couple of questions that have come through. One of them was in terms of patients who want to stop drinking altogether but are struggling. Are you aware of the Jason Vale approach from the book Kick the Drink Easily?
No, it
Heard of
sounds
this? Ah.
sounds like something that would be good for me to read.
Yes.
My suggestion is that we use any resource that is going to actually help a person, and that the key is about matching the intervention with where the person is at. If somebody is at a stage where they're keen to stop, sometimes information on ways in which they can stop work well. And so it may not necessarily matter what they read, because in the end, it's about what do they decide out of that book is going to apply to them. So I would be very supportive. If the person is in a pre-contemplative stage, it's much more important that they read information that is just information about how alcohol might impact on their health or on their life or on their well-being. And so it's about matching where people are at, really. Yes. But thanks for that suggestion. I'll have a look at that.
There's a question that's come through about talking to teenagers about the binge drinking culture, and how it appears to be a rite of passage, especially in sports circles.
Yes.
And do you have any suggestions to talk to teenagers around that?
Yes, so I think, first of all, we're in a difficult situation, as I mentioned before, because the cultural aspects of heavy drinking are not being well supported by anything outside of the consulting room, in the sense of the access to alcohol, even for young people, is easy. The cost is low, and so it's not difficult for young people to get hold of alcohol, and therefore opportunities for them to drink heavily are much easier than they might be in countries where alcohol access is much more restrictive. So we're, in a sense, being asked to do something that's very difficult here, that is solve a social problem in a clinical setting. And I think we have to be realistic about what we can do. If we however, we will have opportunities where we can talk with young people. So injuries are very definitely an opportunity. So every time we do ACC 45, we could think, is this an injury that might be related to alcohol? And to ask those questions. My sense of it is that we need to engage with the person on a one-to-one basis to be able to make any changes, and we need to engage in a way that is appropriate. So the kinds of questions that we've talked about, I think, are very relevant. We're very likely to find a lot of people in this situation are going to be pre-contemplative, because it simply may be that they don't know about the potential danger of alcohol. Questions that you could ask is, are you aware of anybody else in your life for whom drinking has been a problem? Has anybody drunk heavily and got into trouble? Have any of your friends ever had accidents? Do you know about any injuries that might have happened in your peer group or whatever? Because these are actually quite common. You can always then go into alternative ways. Have you seen any of the health promotion agencies' advertisements that are on TV about drink driving? Do you know anything about those? What do you think about those? How might that relate? It's all about really using the same kind of language that we would use with young people in any other way, just to get some kind of engagement. And once we get engagement, then teasing it out. Well, what does it mean for you? How much are you drinking? Do you know about low risk drinking guidelines? These are the guidelines. Here's what you're drinking. What do you make of that? Just really talking about it in that way, and trying to tease out and open up opportunities for discussion. But I think we've got to be realistic about what we can do. We can manage at individual level what's happening with individual people and engage as best we can. We cannot solve the social problems. That belongs in a public health arena.
I like that approach of talking about it in a third person, or slightly removed from themselves.
Yes.
So talking about the peer group and things they have seen, and then somehow relating it back to them, or opening that for them to talk about themselves. There has been a question about, can you comment on how to approach alcohol dependence in pregnancy, and how best to screen in pregnancy?
Yes.
For this.
So first of all, just generally in pregnancy, I think we need to be right up front at the beginning of pregnancy, because we don't know exactly for an individual when alcohol is likely to cause harm. In general, we know that drinking in the first trimester is associated with harm, There's also harm in second and third trimester, of course, but it does seem to vary according to an individual situation, a certain amount of alcohol, a certain status for that particular individual, exactly where they are in the pregnancy. It's very hard to judge, and so that's why we have the straightforward message when asked, there is no known safe drinking in pregnancy. My advice is that you don't drink in pregnancy, and we're straightforward. Then a good question then is, so what does that advice mean for you? What might that mean for you? Is this likely to be something that would be difficult for you? So to get into the dependency situation, you might then, if it's appropriate, you might then ask questions. Well, just tell me about your use of alcohol currently. What has it been? And then go into ideally an audit tool would be a good tool to use. Anything that's going to get you into an assessment around where the person's at. And if a person is then dependent on alcohol, then ideally what we want to get to is an agreement that the person has an issue with alcohol that is making it difficult for them to stop. They're in a situation where they're really keen to stop, where in fact it's critical that they do stop. And so we need an intervention in a way that is going to be very powerful there. And so we would need to work out, are we in a position to help them stop? And again, that's going through the kinds of information that's in the ALAC booklets, or is this something that's going to require specialist help? And would we want to refer to a specialist service for this? And if somebody is willing to own a dependency situation in pregnancy and say that they do want help, I think that we need to be able to either have a full response ourselves, or we need to refer promptly and treat that with a great deal of seriousness.
There's been a couple of questions about medications and alcohol, so we might come back to that a little bit later on. One here is, how would you recommend approaching the conversation with a patient who is clearly drinking problematically, but is very defensive or adamantly in denial about what they're doing? So that really pre-contemplative phase, and in fact, in denial.
So how familiar are we all with this situation, the absolute denial? So what we know when somebody is in pre-contemplative or is being very defensive is that if we attempt to do anything that is strongly advisory or encouraging behavioural change, that we will push them right backwards and we won't get any engagement. So we need to go right back to the very beginning questions here, I use very gentle questions. Is it okay if we talk out a little bit about alcohol? Can I have permission from you to just discuss a few things? Tell me a little bit more about your alcohol use. And then I would just ask some of those very, very general questions. You could go to, is it okay if we complete an assessment of your alcohol using an audit tool? If it's up front and the person is willing to engage. Otherwise, I might go through the you, them, me thing. It's always my go-to if I get caught. So you don't have any concerns about alcohol. I can understand that you're comfortable with your alcohol use. Can you tell me, has anybody else had any concerns? And I might tease that out a little bit too, because sometimes somebody who's being that defensive with you, and if that's a kind of emotional reaction, often that might mean somebody else is actually saying to them, you shouldn't be drinking this way. And if you can get at that, well, what are this person's concerns? What are they seeing? What is it that they're worried about? Oh, that sounds like it might be a problem. What are you thinking about that? Just general questions that would tease out and open up that process. If you can't get anything there, then you go back to the this is what my concern. So, okay, so we've talked a little bit about alcohol. Look, I just would like you to know a little bit about why, as a doctor, why, as a nurse, I am concerned about your alcohol use. Here's some information that I'd like to share it with you. Maybe we can pick up on that in a future visit. I certainly don't push at this point in time. Yeah.
And also here, how often do you find that problem drinking is also accompanied by other addiction behaviour, such as drug use, or is it not often associated? Is it often a separate issue?
So the people who are involved in sort of polysubstance use, it's the same generic issue, but of course it's much more complex because you've got somebody who is using alcohol who may also be using meth or using other drugs on a regular basis, and that can get quite complex. I guess it depends whether you want to address the alcohol separately or whether you want to address the whole of the substances. Depends a little bit on how it gets presented to you. The principles are the same, of course. It's where we've talked about the word alcohol, just put your drug use or your substance use, or so well, tell me about substance use. What substances are you using? What else are you using besides alcohol? And then you could, if you wanted to, go, do you have any concerns about that? What are your concerns? What are your thoughts about that? Does anybody else have any concerns about that? Polysubstance use is an issue from a clinical perspective. There's some things I will be worried about that. Can I share that with you? I'm worried about the alcohol because it can do these things. We know that there's association between meth and these kinds of issues. Sometimes, and if you're not sure what to do, you can just say, hey, why don't we look at some information about this? And if you're confident about it, just Google something about polysubstance and bring up a list and talk about it. If you're not confident about it, and say, look, I'm going to get some information for you. I'd like you to read that, and then I'd like you to come back so we can talk about it. So I think there's lots of different ways to enter into there. But the reality is that alcohol as an isolated issue is way more common than substance issues, generally speaking.
John, you highlighted earlier the opportunities in a pharmacy setting for talking about alcohol, and we've had a question come in around often in the pharmacy setting it seems like we're potentially highlighting an issue of a patient and their drinking when we're counselling on medications such as metronidazole. How do we turn that into a minor intervention in that setting, in a pharmacy setting? Yeah,
it's a great opportunity, isn't it? I guess it depends on how confident you are about the safety of talking in that situation and the confidentiality of talking. But if you've got that as an opportunity to be able to do that, and so you were talking about metronidazole, and say you may need to be aware that you can't use alcohol on that, a really good question is that likely to be an issue for you? Because if it is an issue for you, then it might lead into other questions. So, that might be a problem. Or is it okay if I start this on Monday because I've got a weekend coming up? Sure, that's probably okay to start on Monday, but can I ask you a couple of questions? What are your plans over the weekend? Would that be your normal alcohol use? Tell me a little bit about your alcohol. How many days a week would you have a drink? And just go straight then back into those kind of basic questions. So I think in that pharmacy role, it's almost going back one whole step and finding an entry point into then what the discussions would actually be. But I think the question like, is this likely to be something that you would need to know more about? Is this likely to be something that's a problem for you? Do you have any concerns about the fact that this medication can't be used with alcohol? Those are good questions. Any kind of general open questions that, in a sense, tease it out and then give permission for you to go into the standard questions.
Yeah, it's a fantastic opportunity.
It's a great opportunity, yes.
I think we'll carry on with some of the cases now, and then we'll come back to some of the medication questions.
So this first case is 47-year-old New Zealand European woman who's booked for a follow-up review of depression, having been treated with recently started citalopram. So she has some initial benefit from her medication, but she's unsure whether she can drink alcohol because the pharmacist has added an alcohol caution to the label. So that's good after our last question. So how can we use this opening to understand her alcohol use and any potential issues for her? So this is kind of quite a common scenario for us to be in. So I guess what we want to think about is we've got a couple of options here. One of them is that if there's a labelling warning about care for driving with alcohol, and that's what the label will show, then that can prompt a discussion. I just ask a question similar to what I mentioned before. Look, a combination of medication and alcohol may cause driving impairment. Is that something that would be important for you to consider? So that's just a general point, because if they say, well, I probably would have to think about that, then you can tease out that a little bit more. Well, just tell me a little bit more about your alcohol use. How might this impact if you're taking this medication? And then you can just go straight into how many days a week would you normally be using alcohol? How much would you drink on those occasions? Do you ever drink more than 4 or 5 drinks on any one occasion? And just tease out a little bit about what the risk might be. So that would be a good entry point for that. Alternatively, the diagnosis of depression is also a very good link to the questions. So that's a clinical situation in which alcohol may be a very relevant factor. How do you think your alcohol use has impacted on how you've been feeling lately? Do you think alcohol is a factor in the way in which your depression has shown itself? Insofar as we've been talking about depression, where does alcohol fit in here? Just any kind of general question that puts the onus of thinking about it onto the patient, so that the person will then think, I hadn't really considered alcohol as part of the package when I was dealing with depression, and here's my doctor or my nurse raising it. I need to think about that. And then all of these questions, as you can see, are questions that allow you to tease out and get entry into an area for discussion. Once you open up the discussion with these kinds of questions, generally speaking, that discussion will flow fairly freely. Because if you've got somebody who's coming to you wanting help for depression, and has already started to feel a little bit better, for example, on the medication, then you're in a really positive place to be able to use the relationship that you have, which is, manifested by some successful intervention here, to be able to tease out other stuff that would be helpful for the patient. And they have a sense of, here is someone who's helping me in one area, they're now asking me questions in another area, but probably that's good because good things can come out of this. So I think that's quite a good way of entering into a discussion around those things. And you can see that if it wasn't depression, it was hypertension or some other diabetes or some other area, you can ask the same kinds of questions and get into those answers. So case 2 is Mahana, is a 22-year-old Māori male who presents following after recent ED attendance for a shoulder injury sustained in playing touch rugby. His advice, his x-ray was negative, given analgesia and a certificate for 2 days, and advised to see you for a review. So you think he's got a rotator cuff lesion and you're planning your management using local guidelines. So there's nothing about alcohol in this situation altogether. How can we use this opportunity to screen for alcohol use? He is going to be seeing you maybe today. He might be seeing you for follow-up again. You might well have 2 or 3 or 4 opportunities here primarily around certification and monitoring of progress, which are going to give you an opportunity to get into some other health issues that might be really useful. I would pretty definitely ask permission in this state. Can I ask you some health questions? Look, while you're here, I see you've had this injury. I see you're playing touch rugby. You're probably pretty fit. Can I ask you a bit more about that? Is that your regular exercise? Can I also ask you some questions about health issues generally, about your diet? I'll certainly be asking about smoking. I think those are good kind of lead-in questions. So then it is just now tell me about your use of alcohol. So you see, you might or might not get something out of that. And then I might go through the you, them, me questions. Do you have any concerns about your drinking? I might tease that out a little bit more with some sort of parallel questions around using different words than concerns. And obviously we need to shape the language that we are using to the situation. Does anyone else have concerns? And I might even tease out, your partner, does she have any concerns? Your parents, your friends, even be quite explicit as your boss. Anyone else have any concerns? And then can I share with you my concerns about alcohol? Generally, you don't have any reason to have concerns here because the alcohol use hasn't particularly been obviously an issue. So you say, well, we'll ask all my patients about alcohol because it's such an important factor in health. So can I just check with you specifically, how many days do you have a drink? What do you drink on those days? And how often would you drink more than 5 standard drinks? And then if you get an in that, you might then say, can I show you what we understand about low risk drinking and see where you fit with that? I would probably just tease out a little bit at that visit, and then knowing that you've got that person coming back for clearance or whatever is going to be the certification requirements, hey, I might just touch base with you about what you're thinking about what we've talked about today is at that next appointment. So I guess it's just all about you using the normal language and relationship that you have with a person to be able to tease out how we might do this.
And in here, there was that setting that was brought up in a question before, that sporting culture where there's a lot of drinking that happens, and so asking around what they might see or have seen amongst friends, and is this ever a problem for them? And do they ever feel under pressure, and that kind of thing as well. Yeah.
I mean, because we're talking about language and talking about questions, the concept of externalizing a question is one that's very valid in the counselling world, and something that we can certainly absorb anytime we externalize the question and stop it from being about ourselves or the patient, but being about somebody else or something else. It means we and the patient are looking at it together, and it's a really good way of doing that. So what are you seeing when you're playing? What are you seeing about the drinking afterwards? What do you think about that? What are the rules that the club has got? What do you think should be happening? What might we need to do to change these things? So just any general questions about that engage in a conversation, all raising consciousness and potentially motivational. So that's good. And then the last case is Mr. BJ, who's a 55-year-old New Zealand European man who presents after having some routine bloods, and you notice a mild GGT change and some macrocytosis, and you're aware he's unlikely to come back and pay for a follow-up appointment to discuss something he's possibly pre-contemplative about. So this is really just setting it up to say, you've got a bit of information, you've got a one-off chance to do something about it. Although actually you never have a one-off chance really, because he's going to come back for something else at some stage. But let's say we want to seize the opportunity. How can we use these results to explore about his alcohol use? And be very appropriate to do that, especially someone who's had bloods, because they want to know what the results are, and you can bring them up on the screen obviously and show them to the person. So I always think that's a good thing to do. Sometimes they have them bolded in red or with a big H or something next to them. It's always very alarming when it's a false positive, but if it's a true positive, then you can look at it and say, oh, we've got some things that we do need to talk about here. So I generally just find out, has there been any discussion before about this, because you may or may not know this person well. Has any health profession commented before about these results? Because if someone has mentioned before about alcohol, particularly if there's disturbed liver function tests or an elevated MCV, then you can draw on that. Or what was it they were concerned about? What did you think about that? What's happened as a result of that discussion? So those are all good things that that can tease that out. What is your understanding of possible causes of disturbed liver function tests? So just getting at that person's thinking about it. Most people know that the liver is affected by alcohol, so they may not know very much about it, but so what do you understand about that? And then you have the option to explain the role of alcohol, how it impacts on liver and red cells. I actually use language like alcohol can have a toxic effect on the liver. Sometimes when it's toxic, it will disturb the liver function test, and this is what we're seeing today. Sometimes it can have an effect on red cells in the body, that's your blood cells. It causes them to swell. We measure that, and the measurement on your cells is showing a little bit of swelling. That's something that's showing that alcohol may be infecting, so it's affecting your liver cells, it's affecting your red cells. What we know is those are the cells that we can measure. You've got other cells in your body that are much harder to measure, but it may be affecting there as well. So we know that alcohol can have an effect on your heart, it can have an effect on your brain cells, on your nervous system. So alcohol may be having some effects in your body that we're actually not able to measure, but are quite important to think about. What do you think about that? What might that mean for you? Really just putting that information back to the person. They can always fall back on the 4 L's. It's always a really good one. So that's your sort of 360, and just say, look, can I just check out alcohol with you in a little bit more detail? How it might be affecting on your health, relationships, occupation, legal, as we talked about before. Really just teasing out the different domains and getting a sense of might alcohol be an issue? And out of those things, essentially, we're just really reflecting them back to the person and asking them to contemplate on it, hopefully just drawing their awareness a little bit more around it, so that they either are willing to engage in a discussion or they'll go away and think more about it. And this is exactly where we might give them some information. Can I share some information with you? And that would be when we would text one of the pamphlets. And then specifically might go into assessing stage of change if I think that that's appropriate to do. Have you ever felt the need to cut down? How does it compare with 5 years ago? Has anyone else expressed concerns? Where do you see your drinking in a year's time? Those kinds of questions. So it really depends a little bit on where the discussion goes, and The reason that I suggested at the beginning of the webinar about jotting down questions is that sometimes it's just good to have a menu of questions, throw them out there, get a bit of a sense of what you feel comfortable discussing, where it leads, what might work, and in a sense, after a period of time, you end up with kind of a set of questions within yourself that will just come out almost automatically in different situations, as we do for other areas.
John, we had a question come in saying, does this support the add-ons, ADOMS, that is used for adult alcohol and drug assessment and screening?
Yes, so I think what we're talking about here is the assessment of alcohol within the primary setting, really looking at motivational stage and opportunities for intervention. And the vast majority of people that we're going to talk with, we are going to be managing ourselves, really without a lot of intervention. So for many people, it will be simply brief advice. It will be less than 5 minutes. It will be a mini discussion, and it may, over a long period of time, be a series of mini motivational discussions which have an impact. There will be some people with whom we are going to do an extended consultation, which will involve a more extended, what we call brief intervention, and that's where we're going to set that up. That will be a small minority, but for those people, we make a very big difference. And then there are going to be an even smaller group of people whose problem situation, whose dependency is such that they are going to need a team of people to manage. It's not going to be something that you're going to be easily able to work through yourself, and those are the people that we would be looking at in the referral process.
And a question here, which is possibly applicable to a lot of people listening tonight, is if a person has one drink a night with a meal, how important is it for them to take 2 days off per week for their general health?
Right. So I think that's how you interpret the information, isn't it?
Yeah.
So again, my sense is that there are very few situations in which we want to be totally prescriptive with our patients. There are definitely some. Pregnancy is one. There are some people whose dependency is such that if they drink, they cannot stop. They can't have one drink without having two, and they can't have two without having 10. And so for those people, abstinence is the only way, and they're the ones that you may be considering a lot of interventions, even antabuse and so forth like that. But for many people, what you really want for them is to define their own prescription using the guidance. And the low-risk drinking guidelines are based on population health information that says if our population drinks like this, if everybody drank like this, we would see very few alcohol-related problems because this is low-risk drinking. So I think it comes down to an individual for that person. If that person thinks that having a drink a day is fine, and that they don't have any sense of compulsion to drink or concerns if they don't have a drink, or they're not that drink is not creating any situation in which they can't do what's expected of them, or they are having difficulty sleeping or waking up the next day with any problems, or there's no consequences from that in any way, then they may feel that that's very appropriate. The guidelines suggest you should have less than 2 or 3 daily, with 2 to 3 alcohol-free days a week. There's good research evidence that supports that at a population level. How that relates to individuals for them to decide.
Yes. It's a very pragmatic approach, isn't it, to an individual as opposed
well, all of this is pragmatic, really,
yeah.
because it really is about, like everything else we do in health, the person owns their own health.
Yeah.
We are both educating and supporting them about good ways of being healthy, but in the end, they need to take responsibility for themselves. Yes.
So just before we end, there's been a few questions around the medications that you can use. So we might just quickly have a look at that. And
yeah. So let's just have a very quick look at the medications that are available. Basically, nothing easily is what it comes down to. So I'm very sorry about that. We don't have the equivalent of a Champix for smoking for alcohol. I wish we did. So naltrexone and acamprosate are 2 medications that are technically available to us for people with dependency problems. Naltrexone, it's an opioid receptor antagonist. It's an adjunct to treatment, so it's not the only, you can't just give it, you have to give behavioural support as well. A person to get this medication needs to have a special authority approval, and it's got to come from an AOD clinician. But you can work with an AOD clinician to do this, and if you have somebody that you are managing, it may well be appropriate for them to be on naltrexone, but they need to go through a process to get it. But you may well be the person that's providing support. However, if a person is got that degree of dependency that they would be wanting to be on naltrexone, they are likely to be needing quite a lot of behavioural support. So some of it will be problem solving, and you may be wanting to check in with them, but there will be other factors that may well work better in an AOD setting than in a general practice setting. But again, it's on a case-by-case basis. We all have patients who won't refer to anybody else. It's over to us to manage it. And in that situation, this may well be a very realistic option for that person. Acamprosate is an equivalent agent. It's as effective. It's not available in New Zealand as a subsidised medication, so it's a Section 29 medication, which means that you can get it through a pharmacy, but the pharmacy has to get it in for you. It's quite expensive, but if you have somebody who is very committed to wanting to be abstinent, knows that they need to be abstinent and wants medication to support them, there is evidence that this is a medication that can help. But once again, you can't just give the medication on its own. It needs behavioural support to be effective. So if you are going to be engaged in prescribing that and giving behavioural support, you will need to be engaging with them on a regular basis. This is not brief interventions. This is active alcohol management, which is very appropriate and a very interesting area to be in, but it does take some commitment. And if you feel that that's not appropriate, then that person would be referred. The one medication that's easy to prescribe is disulfiram antabuse. So this is a medication that's not like the other two. This is not a medication which stops desire for alcohol and reduces dependence. This is a controls drinking medication. So this is an aldehyde dehydrogenase enzyme inhibitor. And what it does is it causes the accumulation of acetaldehyde after drinking. So like the same kind of effect that you get with metronidazole. You feel nausea, dizziness, flushing, tachycardia, and palpitation, feel very unwell. It really should only be considered in patients who are attempting abstinence, because obviously if you drink at all on this medication, you're going to feel unwell. So this is for your patient who says, look, I've got a history of alcohol dependence, I've been through treatment programs, I've started drinking again, I want to stop, I know I just need abstinence to help me. I just need antabuse to help me, will you prescribe that for me? I think that's entirely appropriate, but again, all these medications need some kind of psychological support. So either we need to be providing that, or a service needs to be providing that. And there are some contraindications. So if there's severe hepatic or renal impairment, or hypertension, ischemic heart disease, risk of suicide, because it's quite a dangerous drug, and overdose, and obviously metronidazole, we already said, can cause that. But I certainly have a lot of experience with the use of antabuse in selected situations, and for those patients it can be very, very helpful, because if you take that tablet in the morning, you're basically making commitment, I will not drink today, and then as the resolve weakens during the day, if somebody does have a drink, they certainly will know it very quickly and they won't do it again the next day. So it's a useful medication to have, but need to use in a selective circumstance. And if you don't have experience with this as a medication, my recommendation would be to check it out first before you prescribe it, until you've used it a few times, in a sense, with support, so that you know where it's appropriate to use.
John, there's a question there. Is it okay to use this with treated, well-controlled hypertension?
Yes, it is. Yes. Yeah. So again, like all medications, just look up to see what the interactions are, but it would be appropriate to use in that situation.
Okay. Brilliant. So I think that's wrapping up. Do you have any last words to offer there, John?
Is your drinking okay? Well, there is wisdom in our patients and resources there, and so I would just encourage an entire approach that says alcohol issues belong with the patient. The patient knows where they're at. Sometimes they need help to tease that out. That's our job. Sometimes they need support to change their behaviour. That's our job to initiate that, but other people need to be engaged in that, particularly significant others, whānau, family, other people need to be engaged in the process. Intervening in alcohol issues can be very successful, It's not difficult, it just requires practice. And my final words would be, test out a few of the questions over the next week or two, and just see what comes out.
Yeah, thank you, John. You've given us a wealth of information about the tools and those questions that we can use, and allowing that brief intervention to happen. So we really appreciate your time this evening. Thank you.
You're welcome.
Thank you, everyone, for coming, and we'll sign off, and thank you for all your questions and the great conversation. Good night.